And with that, I think we're ready to go to the next paper, Dennis Shea's paper on the quadruple aim. This is again the first of the case studies, and this one is about social drivers to care and health-related social needs.
My name is Dennis. I'm currently at Harvard UCLA, trained with Harrison and the crew at Highlands. And I guess reflecting on what we've heard this morning, I've edited my slides already. I think, just in terms of what Dr. Goldfrank said, his picture of the Norman Rockwell physician painting shows a point that was brought up earlier of how public health and medical health have sort of diverged. I think you see in this picture, the physician is not necessarily, doesn't look like he's necessarily in an office. He might be in someone's home with his little black bag. And I think it was brought up earlier in the conversation that we, as a profession, have lost sight of the things that most affect our patients often because we are now isolated within the four walls of an emergency department or of a hospital. And I think, I actually, for one, feel relatively useless outside of the four walls without all my nurses and equipment. But I think, sort of framing back to this paper, I know the issue was brought up was that we may disagree politically on the mission, which I take issue with. I actually disagree with that point. I think it's hard. I think we all agree on what the mission of medicine should be. I think, sort of the triple aim illustrates that. I think you're going to be hard pressed to find a physician who disagrees with the idea of improving population health, improving patient satisfaction, and reducing per capita spending. I think people all think, yes, those are all principles we can get behind, and so do the legislators. And that's why we have this, lots of metrics imposed upon us. But I think, initially you may think this is great. However, I think as busy physicians, as we've talked about, when we start thinking about this some more, we'd be like, that would be great if we didn't go home every day and feel like we don't have enough hours in the day. I think this gets to the issue of both burnout as well as the idea of offloading. Where can this division of labor go? And I think this is how the quadruple aim probably came about in some senses. I know burnout's been brought up a lot, and thinking about how do we include provider wellness in a space where we're asking people to do more and more and more with the same amount of time, no payment. But I think this framework also provides an opportunity. I know Dr. Hoffman said that culture change takes a long time, but I think I'm a fan of forced culture change, and like Dr. Anderson, I'm a pragmatist. So I think this framework provides a way where we already have the exact framework we need to address social determinants. And what I mean by that is, as I sort of mentioned in the paper, we're spending a ton of money on healthcare. We're spending more money than most other countries on healthcare. So it's not a lack of spending of money or energy or effort on healthcare that results in our poor health outcomes. It's really, are we spending this money wisely? And I think in that comes in, this framework. Everyone's been tasked with this very broadly. This is what everybody's talking about. Your administrators are talking about it, even if you as a physician are talking about the quadruple aim. So I think we can fit the idea of addressing social determinants into this framework. And, I think the idea of cost came up. And it's really interesting because, cost efficacy is one piece of the puzzle, but I rarely see in emergency medicine us focusing on cost. We focus on what cost reimbursement. We focus on what we're paid, right? And I think, you see this in the door-to-provider thing. Everybody has implemented some sort of rapid medical screening exam or medical screening exam because we're now judged on door-to-provider. Is that actually changing outcomes? I mean, I can tell you at Harvard, we've basically changed our left without being seen to left without treatment complete for a large part because people are now just getting their test and then leaving because they don't want to wait for a number of hours. So I think, we as a group, for better or for worse, are partially incentivized by payment. And I think, thinking about a common language, I think we can use this to our advantage in terms of thinking about, can we not force people, but can we structure payments in a way that screening and addressing social determinants results in people getting paid? Because if you're going to say, I'm going to tie your reimbursement to this, regardless of whether it's cost effective, people are going to pay attention. I think, you're thinking two different audiences. Cost effective is bring the policymakers to the table, right? Those are the people who are going to say, yes, we support this grand idea because it's the right thing to do and it saves us money. For your line emergency physicians or even your hospitals, they are mission oriented. Everybody has a mission statement. I don't think any hospital's mission statement is to go out and kill patients. But I think at the same time, everybody has a different way of implementing that mission statement, and that's where we run into politics. And I think if you can tie payment to your end result of screening for social determinants, that's how you sort of get people there by saying you're doing the right thing and we're paying you for it, regardless of whether or not they agree with how to do it. So I'm going to throw that out there for thought. And I think this sort of gets to emergency medicine. I've seen a lot of great mentors in emergency medicine, and I feel like emergency medicine's model traditionally is just do it, right? We're sort of scrappy, we fight all the fights, claiming different territory. However, we tend to medicalize things, and I think Dr. Rodriguez pointed this out in his comment response as well. We medicalize this, and so do patients. Patients are pretty rational, right? They know if they're with a police officer who's going to take them to jail for being homeless, if they say they're having chest pain, they're more likely to end up in the emergency department, and that police officer is not going to want to wait around for 2 troponins, and they're probably going to get off. And I think, we've sort of created a system where we foster and encourage this kind of behavior because we're not willing to pay for things like housing. And, reflected in our spending, it's very much, we are very interested. We don't spend any less or more money overall as a percentage of GDP. We're sort of smack in the middle if you look at healthcare and social services together. We just spend a lot of that money on healthcare, not very much on social services. And so I think sort of switching what we pay for, what we're incentivizing people to do, we should change the model of emergency medicine to not just do it, but just do the right thing. And I think by incentivizing this through payment, it's sort of the right way to get us to that goal. And I think in terms of, thinking about emergency medicine, I think of this graphic where you have most emergency medicines are at E1, where they're doing their thing, they're seeing 4 to 6 patients an hour, they're worried about reimbursement, they're worried about all the metrics they're held to. And then there are a few people, such as many of the people in this room, who are at E2, who are very excited about this, thinking bigger picture, thinking about social determinants, and really trying to push policy change. And I think Dr. Freeman-Garrick comments that, one thing that the paper doesn't really address is how do we get people involved in advocacy? How do we tell our patients' stories? And I think I'm going to push back a little bit saying, I think that's a great thing that we should do. But at the same time, I think that's not for every emergency physician. I think many emergency physicians want to get through their shift. They want to feel like they made a difference, and then they want to go home and do everything else. There are people who are interested in doing that and also going out and advocating for patients. So I think we have to reach that balance. And I think my paper is really trying to focus on how do we hit that first level of, just doing some screening, getting everybody involved, accelerating that culture change, as opposed to thinking about how do we get those who are more interested to that higher state out to do more advocacy. And I think, like Dr. Freeman-Garrick is way ahead of many of us as she is clinically, as those of us who trained with her know. She's another level above, and I think that's a fair point for everybody to strive for, but I don't think every single line emergency physician is going to get to policy advocacy. And I think incentivizing correctly is sort of the bottom line in terms of screening. And I think, basically we have to make it easy to do the right thing, right? We have to make sure it's aligned with finances because we know that drives many of us in part, if not everybody. And we have to sort of show some results. And I'm sort of going to focus on the first 2 buckets. So I think easy, Dr. Freeman-Garrick once again comments on, we are overburdened as a profession. We're asked to do so much stuff. And asking an emergency physician to go through a social screener of 30 to 40 questions is just not going to happen, right? However, this is a team sport. There's scribes, as you mentioned, there's nurses, there's medical assistants, there's registration staff. And we see some of this already offloaded to other individuals. We see, for example, at Highland, domestic violence screening is done in triage by the nurses. And the physician's job is to acknowledge that, see whether or not the screen is positive, or see if the screen makes sense in the context of the patient you're seeing, and then be able to delve into it if that is relevant and appropriate for what that patient is presenting for, or as a part of the reason why they're presenting. And I think much of this can be done with social screeners. There's no gold standard for a social screener right now, but I think in terms of thinking through how do you implement universal screening, which I think should probably happen in every emergency department, it's really, I think there's one, which is the research question of what's the right set of questions to ask and how do you ask them. But I think there's also an implementation thing closely aligned with that, which is who asks those questions and what do you do with that? And I think, we've talked a lot about the emergency physician, once again, being a jack of all trades and really working with the consultants and not going at this alone. I think several people made the point earlier that we have to identify the issue. Whether or not we are the one who call the shelter is probably a different story. But whether or not we're leading that effort in terms of saying this is well within our sphere of what we need to address, making that stand and marshaling the system resources to say that, yes, this is within our scope. And yes, personally as a physician, I may not be calling the shelter, but I need a team to do this. And what does that look like? Is it a social worker? Is it a patient navigator? Is it community partners who are willing to take that call? So my social worker is not on the phone for 20, 30 minutes on hold. I think it's sort of looking both within the hospital, what infrastructure you need, and also outside of the hospital, what relationships you need to build. And
I think we're at time.
Okay, sounds good. So I think the second point very quickly is just money. Once again, we have to think about shifting. If we're shifting money, every dollar in healthcare is spoken for. Are we going to shift more money out of healthcare into other resources? And what does that mean for everybody? And does that mean cost effectiveness? Does that mean emergency physicians get paid less? I think it's an open question. And result is what we're here to discuss. What's the research agenda? That's pretty much it.
Thank you.
All right, we'll move right to Jocelyn.
Okay, hello everyone. I'm Jocelyn Freeman Garrick. I have the pleasure of serving as an attending at Alameda Health System Highland, and I've worked with about 10 people in this audience from my Highland family. Thank you, Harrison, for inviting me to comment on one of our baby's papers, Dennis. As you can see, Dennis is a classic emergency physician who is all over the place, but brilliant in his mind. And I summarized his paper down to two things. He suggested and gave us some tools that all of us could do. We should screen for social determinants of health. We screen for cardiac risk factors. We screen for sepsis at the doorway. Why aren't we screening for these other factors that we know impact our patient's health? And I agreed with that. He also talked about sustainability, which was tied to cost, maybe. And both of those things I felt would involve policy change for sustainability, money, resources. I agree that emergency physicians aren't trained to be advocates and policymakers, so I'm not suggesting that we do all of this, but I did talk about what Dr. Ewan talked about from Stanford, that we need to at least be educated and know what the resources are and have multidisciplinary teams that we are aware of who can address these issues. So I do think that we, at least in medical school, to start with the babies who are built and ingrained in them. This is what social determinants of health are, and this is why you should screen for them. It shouldn't stop there. We should do it in residency as well. All of us have local public health departments. How many of us have a Dr. Jonay and know that you can give us access to public health resources? I think your situation is unique. We need to know that. But I don't know if that's standard across our country where we're talking to our public health departments about what we see every day in the emergency department that represents the societal ills and the changes that we're seeing. Like in Alameda County, we're seeing a lot of medical marijuana and the side effects from that. We're dealing with human trafficking. Are we communicating with our public health department, and do we know how? I heard a young lady speak in Orange about policy, and I heard Dennis talk about policy. They're both JDs. I don't have that policy background. It took me 10 years of working in my department before I met one of my board of supervisors, who then gave us a grant to start a reentry program for people with backgrounds, and then gave us another grant so we can hire young people from the community. So I was like, wow, it's all about relationships and talking to the right people. Are we teaching that to our residents and our postdoc fellows and our medical students? So I suggest that that's an easy fix. That's something, just changing the curriculum at multiple levels that can be implemented. So that's it. It's a nutshell for the education and training. If we're screening, though, I think I suggested we can't screen and not have a solution. We don't ask about the social determinants of health, and then what? That's a lot with medicine. What are we going to do about it? So that would be a bigger challenge for us to at least work with the community. We're not here to fix it all. There are resources available in our community that can be a hospital-wide approach, a public health department approach, a partnership where we identify the resources after we see regionally what our problems are. I do think that the screens would likely be local. There are some things that are universal in the United States, but not everything. What I see in my urban community may be different from what you see in your community, or what Appa sees even in the same city, but it's a community hospital. So I do think you should vet and see what your determinants are and then screen for those. I think I finally suggested that we have to incorporate workforce development. It's another easy fix that I thought as one of the root causes. One of the root causes that I see is unemployment and underemployment, which leads to poverty, which leads to poor health access. And a lot of us are in health systems that employ thousands of people. And the people we treat, are we giving them an opportunity to work in our system? That's one of the best practices that we do at Alameda Health System. We've just started in the last 3 to 4 years to hire young adults from our community and implement that through pipeline programs. You can do that. I've been given the red bomb. Dennis, I think you took all our time. But
she can do that.
I'll stop here. Thank you.
Rob?
So I'm Rob Rodriguez. I'm from San Francisco General, UCSF, and I'm also honored to be in such a great group with such great minds and such kindness. There's a whole lot of kindness here that more so than just about any room that I've ever been in. I'm going to try and avoid some redundancy. We've heard a lot about changing the kind of the attitude in general about this, and I want to make two points. How many of you watched TV last night, 2020? Did anybody see it? So on 2020 last night, one of our colleagues was emergency medicine. They had a show about the good doctor, and they had all these. They had 3 or 4 different doctors, and they were all in dramatic scenes. You know, one of them was literally pulling a bomb out of a patient. It was in a battlefield scenario, and they were pulling a bomb out of that. You know, so my point is, these kinds of issues are never going to be, sexy and appeal to the mass audience in that fashion. However, like a few people have mentioned, we can tell really heartwarming stories. We can talk about, stories about like an immigrant patient that I saw in the ED, a 7-year-old girl who was complaining of abdominal pain, and when it really came down to it, her concern was that her parents were going to be deported. And so, we can tell stories that can appeal to that audience. as opposed to the, in contrast to these, dramatic trauma, life-changing, what the public perceives as life-changing kind of emergency care. So we can still create some meaningful stories with our patients and with our residents. We should approach it as just like we have the save of the day in terms of trauma. We can have the social services save of the day, and conversely approach it in terms of QI and M&M. If we miss things, we should miss things in terms of social determinants of care. We should also point those things out. So I think while we can't, we're not likely to achieve that sort of dramatic pulling the bomb out of a patient, thoracotomy kind of excitement, we still can build excitement in other ways. The other point that I wanted to make, and I discussed in my paper, in my commentary, is thinking about it from our actual patient's point of view. So our immigrant patients, our homeless patients, and we did a small study a few years ago, looking at, we did two studies, that one of them looking at the fears that immigrant patients face in terms of deportation. It's a real fear. We're doing a repeat study of that now. And another study, we looked at homeless patients, and we asked them, we just outright asked them, why did you come to the ED today? And almost a quarter of them would admit that they came for either food, shelter, or safety. So we have to think about it from the patient standpoint, from those patients' standpoint, and try to avoid medicalizing their complaints. When a homeless patient comes in and they're complaining of chest pain, do you think they're really comfortable in doing that? They obviously feel conflicted. They're obviously very, they know that if they say that they're hungry or they're cold, they're not going to get care. So we need to make it okay for them to make that complaint, and not force them to medicalize their complaint. And I think that really there has to be kind of a paradigm shift. And the shift would be for patients to allow homeless patients and other patients to express these complaints, and perhaps basically avoid coming into the ED for medical care, and sort of shift them to social services type, subsistence type care. And that whether that shift occurs at triage, where I think it should occur, before they get into that cascade of EKG, serial troponins, whether it occurs then or soon after, we really need to make that point. So and that comes back to reimbursement issues as well. It has to be okay for us to document. It has to be okay for us to document that this patient is here for this, instead of having to make up a diagnosis and saying abdominal pain or something like that. The red.
I have two. Hi, I'm Roberta Kapp from the University of Colorado. I have two comments. One straight from what you just mentioned, and one that's separate, and wondering if this could be part of this agenda, either of today or tomorrow. So in regards to your comment on the medicalizing the social issue, I think we just have to be very careful with the assumptions that we make about why patients are seeking emergency care services. And in labeling, saying that if they're coming in with chest pain and they're really here for housing or shelter, it really sends kind of the wrong message to my perspective, and to the trainees and to the entire community about not really understanding the entire complexity of why patients are really seeking care. So I think there's a very delicate balance there. I understand where you're coming from, and I understand that patients do in fact see us as a safety net, not just for medical, but for other things. But in making some assumptions and correlating the medical piece with the social piece, I think it's taking a step too far. And then the second comment that I had was related to the entire group, because my mind is just spinning a little bit. I've heard so many great things, and one of the things that really hit me is, what is our role within this entire system, and how do we define our role as physicians and what we're doing? I heard screening. I heard the role of the physician is to then address it with the patient. I heard we're making phone calls for the patient. I heard so many things. And so taking a step back and really understanding what is it that we're asking for of ourselves as providers to play a role in. I will never be as good as my social worker, I can tell you that. So I don't think I should be the lead in doing all this social work stuff, because she is the best person ever. She's my team member, and I rely on her. So I think defining the role is really important as we move forward with any agenda related to this.
Just piggybacking off of the idea of what the roles are, and sorry, it's hard to face the microphone, but I think everyone's going to have a different role. I think some people are going to be really great at implementing a help desk like Dennis did, and some people are going to be excellent advocates at a policy level, and some people are going to be, I just think that one of the things we have to do is present some options. And part of what I liked about Dennis's paper and the commentaries is that there are some really practical things that we can focus on. This is one option. This isn't something that everyone, I think, is going to adopt, or that we should expect everyone to adopt, because I think some people we're all going to have different strengths with this, and everyone comes here with different interests too. So I think this is a great option. How do you integrate screening? What are the answers? How do you not interfere with flow? That kind of thing. But it's also not going to be everybody's area. So I think thinking about our role as emergency physicians in social emergency medicine, it's I think everyone's going to be researchers either, for example.
I'm going to take a step back then. In the clinical setting, I'm going to start very small because I understand the big picture. But in the clinical setting, what is our role as emergency physicians? Is it to do the screenings? Is it to address the issue? Is it to have our counterparts do certain things? And as a specialty, are we bringing that in as part of our services? Are we saying that care management services are a necessary piece to what we do every day, and then we'll take on that particular activities for the emergency medicine community? So I'm just going to take it down. I understand where you're coming from with a policy level and advocacy and neighborhoods and all of that, but within the emergency department, clinically speaking, what is our role as providers?
I think we have Stephen and then the microphone and then Joni.
I was going to make some brief comments, but I really want to get at this question, and I think we can. First of all, I really enjoyed the paper, and the graph that you showed about the disproportional spending of United States healthcare and social care is really striking, and I think it's first time I've ever seen that, and I think it's a great element of the paper that you've done. I'm also reflecting on the fact this is the first conference I've ever been at where the subject of kindness has come up, and I really want to applaud Robert for bringing this up. I never really have been at conferences where we're diving into so many things and discussing so many important things that affect our patients, but it's the first time, so thank you. I've been thinking a lot about what do we do in the emergency department, and again, perhaps we can talk about the common threads, Harrison, that are being identified in all of these papers and commentaries, which I'm finding to be absolutely fascinating. In my paper to respond to Thea, I talk about the biopsychosocial diseases that we see every day. Our role as emergency physicians is to understand those biopsychosocial disease patterns and understand that we come with a really strong bio portion of that. We can evaluate chest pain really well, but in the context of our seeing the patient and talking with them, we understand that there may be some other elements of psychosocial elements that are actually stronger, and we need to recognize that sooner than later to pull in our team members of social services or clinical psychologists that are now being embedded in trauma centers, perhaps even in emergency departments that they are at Henry Ford, where those elements, that's our role. We are physicians, we are trained to deal with diseases. And in framing our patients with that biopsychosocial disease, I'm not concerned about medicalizing, and I think it's framing it in a way that's appropriate and thus places us in a position of responding in an appropriate way that's not disproportionately medical. Your opponent's negative, see ya, but really knowing when to engage psychosocial team members to help with that particular patient that's in front of you. I don't feel that you find that to be helpful, but I found it to be very helpful to frame it the way it makes sense to physicians. That's what we do. We manage diseases. In this case, we're recognizing there's a lot more to this disease pattern than chest pain, rule out EKG, troponin. There's something else going on here that we need to be better at recognizing. And then once we do, we then get the team members who are appropriate to pull in and come into that.
All right.
Oh, sorry.
Yeah,
Oh,
you're up.
I just did Margaret, yeah.
I'm
Hi,
sorry.
I'm Margaret Good-Erickson.
I apologize.
No worries, I thought you were looking over there. I am a National Clinician Scholar at the University of Michigan, and I'm also a rural health researcher, and we're moving to the University of New Mexico in the next few months. I feel like what I'm hearing here in the last few minutes really actually sounds like a research question, and I know that's one of the goals is to start generating some of these questions. And some of the work that I'm doing right now is with FQHCs and social determinants of health screening in FQHCs. And what I think some people have said today is thinking about looking outside of the emergency department for collaboration and other places that have been doing for a long time a lot of this work that we are now thinking about trying to do in emergency departments. And what I'm sort of hearing in this research question is, what's the role for screening in emergency departments and how can we best implement it? And be that, you know, maybe not the physician themselves, perhaps other people in the emergency department, but also thinking about what community resources we can pull into this as we're starting to think about developing social determinants of health screening programs in emergency departments, with the knowledge that many organizations in our communities have been doing this for a long time. You know, FQHCs, community health centers, have been doing social determinants of health screening for years and have developed, you know, best practice guidelines and things like that, and thinking about how we could work with FQHCs, work with public health organizations to help use some of their models of care, or even potentially their resources, right? People have pointed out, like, okay, we're screening, but then what do we do when we identify that there is no, this person has food insecurity, for example? Well, we know, like, you know, FQHCs have really good access to getting people on the SNAP and, you know, helping link people to the social need, to the resources that exist. And so I guess I'll just close by saying, I think, you know, one of the critical questions that sounds like we're all trying to get at here is, how do we most effectively, with sort of the resources available to us, both time-wise and also actual physical community resources, how do we best implement screening programs in emergency departments in a way that meets our unique community needs? I will say, as a rural health researcher, that in the work I'm doing with FQHCs, we have found that there is high variability in what rural communities need in terms of social determinants of health resources versus, say, urban communities. And I think it will really need to be tailored as well. Thank you.
So we have Joni, then Rob, then we're back to the microphone.
One thing that I thought about, and this may be taking us a little bit off track, but it's something very simple that I think everyone in this room can do as emergency physicians, and what we can help our colleagues who just want to be good ER docs do, is just remind us that we really just need to be a good doctor. And part of that is just recognizing all these people we're talking about with these social determinants, they do actually have higher risk of heart disease and heart attack. So what I found so many times is that our residents are, and other, you know, colleagues attending college, they kind of belittle the medical complaints because they're focusing on the fact that, oh, it's a drunk, It's someone who, they're here every other day. I mean, I literally infamously sent one of my residents home once because I asked her to see an intoxicated patient, and she said, oh, whatever, that's not interesting. He's just a drunk. End up being hypoxic and almost dying. But again, we often miss, because we're so focused on these social determinants and thinking about, oh, they're just here for chief complaint of homelessness, when actually they're actually more sick. So I think, if nothing else, we can be the ones. I taught this lecture at the University of Maryland when I was faculty there. The difficult patient. What is a difficult patient? It's the one who doesn't follow our instructions, doesn't seem to understand. They say they want to leave AMA. Well, actually, they've got a lot of kids and no child care. That's why they're leaving AMA, not because they just don't want to follow physicians' orders. So I think reminding us all, again, at the end of the day, we need to be good doctors. And part of that is understanding the relationship between the medical components and the social determinants.
So we're back at the microphone for two, and then Eric, and then me. Oh shoot, Rob! I forgot Rob. We're back at the. Rob was first. I apologize.
I wanted to clarify what I meant by medicalization of complaints. Mm-hmm. What I meant is empowering these patients. In other words, allowing them to truly say what they're there for. And if we can set up a system in which they're allowed to say what they're really there for, we can avoid the scenarios in which the kind of boy who cried wolf scenarios, in which we fail to recognize these patients are truly medically ill as well. If we allow them to say what they really are there for in a shameless manner, without having to medicalize it, then perhaps they can, when they truly are having other medical issues, we can be more exact. We can sort of focus our care on what they're there for. Basically, really want to try and take the shame out of or the conflicted nature of having to present for these complaints away from them. Not by any means trivializing the fact that they have comorbid disease and that it kind of relates into the rest of it.
Microphone.
So I'm not a research scholar. I'm just one of the more senior people in this room that's had a lot of experience in a lot of areas I want to share a few thoughts with. I'm Art Hengerer. I chaired an ear, nose, and throat department at the University of Rochester. I run the Medical Conduct Board for New York State, and I'm just finished being the chair of the Federation of State Medical Boards. So I'm not part of your realm, but a couple of thoughts that I want to share with you. One is how important what I hear is going on in this room today for patients, but also for physicians. This social concept that you're talking about, it's not just about emergency room doctors. You need to get the buy-in of all the doctors everywhere. And I'm thinking about, as a head and neck surgeon, the most tiring part of any resident and physician's job in otolaryngology is taking care of that head and neck patient who got cancer from the behaviors that he was involved in, and you struggle. It's not like you see that patient one day in your emergency room. You spend weeks taking care of that patient, getting them through their surgical procedures and out of the hospitals with all the complications they had. So whatever you can do to begin to understand how to train physicians in dealing with these kind of problems will trickle down and be a terrific benefit. The second part of my career, which is now in regulation and being involved in these other boards, is that I hear about the culture, and I hear about how do you decide what you have to do and where do you put your effort. And so in the Federation of State Medical Boards, the effort that's going on right now in one big way is related to physician wellness and burnout. And the effort that I took on is we have to change the culture of how we ask doctors about their mental health status. It prevents them from wanting to go and get care. And if they don't go and get care, their health is bad, and then they're not a good doctor. So that's an area that we really need to look at and try and address. And the other part of it is how do we help that physician once they get into trouble? Every month I sit and probably review a license of 20 doctors in my state. And how much of that is burnout and how much it is those daily work that you're doing in the emergency room and the impact it has on you. We don't look at that at all when we go about thinking about disciplined physicians. We look at what did they do in that particular case and how did they handle it medically. And so what I'm trying to get our board to do, and I hope we can spread around the country, is when the investigators investigate, what was that practice like they were involved in, and what was the behaviors going on there, and what was the stress that came from the organization they worked for. 80% of burnout is the organizational problems that exist. It's not the physician. So how can we look at that? And then when we modify what we do in terms of monitoring and probation and whatever, is how do we say to that physician, you can't see 40 patients a day and work 9 hours a day and go home and spend 2 hours on your computer at home at night. This is what you're going to be allowed to do, and modify their whole wellness pattern. So I think that it's wonderful we're spending time talking about what do we do for finding out about that individual, but I think don't forget about the doctor that's having to put their time into these efforts, and how can you help that? Because that will make them more interested in trying to help their patient because they're realizing how they have to get healthy. Thank you.
Thank you. So Jerry, Eric, me, Lou, and Maria.
I'll let why don't you go first? I'll wait.
Okay, I'm going to give the floor to Eric then because he's next in line. Are you sure?
Yeah, I'd like to hear that first, okay?
Okay.
I feel like that's a lot of pressure. I was just going to say that I really appreciate what you said about part of what we can do is just, I think we're really lucky to be in a profession that what you can do every day can improve population health. And the example I thought of is there was a IHS ED in the Great Plains area that shut down in December of 2000. What they really needed there was just an emergency department. And so we do have such a practical skill set you can bring.
Are you ready? Okay, I'm also going to remind, especially it's hard at the U here to make sure that we're including everybody in the conversation. I wanted to just tie together what Dr. Hengerer was just talking about with Dennis's paper, which is this burnout issue. That Dennis added to the triple aim, the quadruple aim of reducing physician burnout. Now we know from a paper written by Leah that one of the reasons physicians don't engage in social determinants is that we don't know what to do with the information. And what that makes me think of is the people who staffed emergency departments before we had training in emergency medicine. So if you think our burnout rate is high now, and it is, it was stratospheric in those days. People would do emergency practice for 2, 3, 4 years and then move on, because they were doing things every day. They were confronted by problems that they had no idea how to handle. And practice doesn't improve that, right? If you don't know how to handle it the first time, and nobody's written about it because there's no practice of emergency medicine, so you can't go home and read about it. You see it the next time, you still feel like you may be mismanaging it. The path to burnout is very rapid. Well, if we look at the incorporation of social context into the provision of emergency care, I think we can see a really tight analogy. And that is, if we teach emergency physicians how to manage this on a day-to-day basis in their clinical care, first we have to figure it out, then we have to publish it, and then we have to teach it. And that will, I think, take us back a few steps in our burnout pathway, because we're now equipped to deal with something that we see every single day in our care, and we're not sure if we're handling it right. We know empirically that we're not sure if we're handling it right. We've measured that. So if that's contributing to the burnout in emergency medicine, I think that social emergency medicine has something concrete to offer the practice. By training emergency physicians to incorporate social context, we will be reducing their risk of burnout. That's my opinion. And now finally Jerry
Yeah,
is.
I guess your comment is along the lines of some of what I want to say. You know, I'd like to go back to the question of what do we do as doctors? What do we tell the emergency doctor to do? And one thing we should tell each other is that we're not all doing the same thing. Okay, there are going to be people who are going to be taking different roles. We're going to be doing research. We're going to be taking leadership roles. We're going to be part of a team, etc. But the fundamental question is, what do we tell is the basic thing that all of us have to do. So I'd like you to think back for a second. When you see a patient in your emergency department now, what do? You do a history and physical, and what else do? You write a long chart. You spend a lot of time with a stupid chart, including doing things that we all know are totally useless. We all document the review of systems. There's not a single patient I've ever seen in 40 years where that helped me take care of that patient. We're forced to do that because we don't get paid otherwise. And of course, that leads us to lie, and we make up things. We say we asked things we didn't do. Why should we be asking about social determinants? I don't think this is about screening. I think the reason we all need to be asking about this is because you can't take care of your patient unless you know about what's the reason they're there. And it's more than just about allowing them not to feel shame, which I love when you said that, Rob. But it's more than that they can acknowledge why they're there without being shamed. It's because you can't take care of them without knowing why they're really there. But it was a critical point here, which is that if we incorporate this into what we do every day and then make us all feel useless and helpless because we don't know what to do with the information, that's only going to increase burnout, and it's going to make all of us abandon trying to do this. We're going to think it's a useless behavior. So one of the critical things we have to do is, before we even start asking people to ask, is to say, what tools are we going to give you so that you can use the information in a way that actually helps your patients? There's a huge amount of literature out there in the world of public health, but also in medicine, which shows that if you address social determinants, you get much better outcomes than if you address troponins. Certainly get better outcomes than if you do extra CTs. But our doctors don't know that, and they don't know how to use that information. So I think we have to go in a little bit in an orderly fashion. We have to teach people what are the tools we have to help address the deficiencies that lead our patients here because of social determinants of health. How do we access them? How can I, as a pit doctor, get help even if I don't have a social worker in my department? How do I advocate to have a social worker in the department? This is a very complex thing, but we have to first have a framework where we can use the information, and then we have to just teach people the truth, which is that the information is really important. It's far more important than doing a complete physical exam. It's far more important than a CT scan or a troponin in most of our patients. That's why we do it, not because we're being do-gooders, but because that's the only way we can affect the health of our patient population. So I think it's not a simple answer, but we have to address each of those things. We have to teach people what resources there are that you can use this information in a way that'll help your patients, and then we have to have them understand that it's an important thing to do, because it is an important thing to do, not because we're nice people and we want to do good.
Thank you. We have Lou, Maria, back to the microphone. And then 1, 2, 3.
Maybe I'll pass. I haven't heard Thea speak all day, so like.
Yeah, I'd love to hear Thea.
Oh, now?
I'm passing.
Well, Maria's after Lou, so.
Please. Okay, thank you.
Very much, please.
Thank you, Dr. Frank. I appreciate that. I just wanted to respond to the last comment. I just quickly wanted to say that we don't always have to have a formalized, built-up system to address the social determinants of health. There are some very basic ways we can begin to address it. For example, my residents know not to present any case to me without having all the answers to the why, because they know I'm going to ask it. I mean, they can't come and tell me I have a 40-year-old guy who's here all the time, at least 3 or 4 times a year with his blood pressure out of control, because they know I'm going to ask why. And they can't tell me he's probably like non-adherent, and because I'm going to ask why. Because none of that stuff makes sense to me. I mean, it doesn't make sense to me that given any opportunity, a person would choose suffering. So you can really start at some very basic questions. The patient I just spoke about, for example, when I went to talk to the patient, and then, by the way, the resident went to the electronic medical record and opened up his primary care visit history, and he saw a smattering of no-shows. And then he had you could really substantiate what he was claiming. He said, see, I told you, he's non-compliant. When I go to talk to the patient, he goes, oh yeah, I have health insurance, I have a family, I have a job, but I can't always afford the copay. So I take the medicine every other day instead of twice a day or every 3 days. I'm trying to stretch it out, thinking that it's going to be equally effective. And then he said, and the hospital sends you random appointments in the mail. As I said, I have a job. So if I don't go to work, I don't get paid. But, we have created this narrative about who this person is and missed an opportunity to intervene. Because both those things, at least in my hospital, are fixable. We can, there are these things you can connect, these programs we can connect them with in the pharmacy to give them, you make sure they can afford the medication, and also just bother to make the appointment with the person, so that that they can come. So there's some very basic tools we can use, as we've been saying all day, as a paradigm shift, in our approach to the way we care for people. Because I'm with the last the person who commented, it's like, why bother, if what we're doing is not going to have any effect?
But you have to let people know that those tools exist, because most functioning emergency doctors think, oh, this guy's got a job and he can't go, and how can I fix that?
Well, you can begin by engaging with the person.
Of course, but
I mean, it's just like basic.
people have to be hopeful. They can't be
Talk to 'em.
hopeless.
But people don't ask those questions. They don't. I mean,
They don't.
Crazy.
It's a
They
difficult
don't.
patient. They're non-compliant.
Every
They're-
time. It's also the training, though, and not to blame any millennials in the room, but I am a little older, and it's so technology-based, and we've seen that we've lost that art from the pictures that we saw in the PowerPoint, and just spending more time with the patient and knowing that the answer is 85% in the history and talking to them. And usually when you talk to them, those social determinants come out, as you said, Dr. James, in the conversation, but it doesn't come out if we don't spend enough time with the patient. We focus on the medical, the patho-phys. But that could be taught. We can get back to that with education and a whole person approach.
Can I push back a little bit on how can we align what we're talking about with national metrics when it comes down to length of stay and hospitals being measured on that? That's counteractive of everything that we're talking about, right? My care managers, when they're spending time with a homeless client, they take longer than the medical care that's provided by the provider, which is the way it should be if they're doing the right thing for that particular individual.
Right.
But yet no hospital administrator, or when we're looking at numbers nationwide, is going to approve that process because.
Is it because we're not talking to them?
But it's not necessarily increasing your length of time. It's how you ask the question. The same amount of time, ask it the right way and listen to the people.
No, I
And
mean,
it saves you from having to go back 3
and
times
the
because you come
intervention-
present to you and they're like, go back.
And
You
the,
didn't
no, I'm talking
I'm
about the
having trouble here.
intervention period, right?
Yeah.
When the social worker is going through and trying to find them the right place to go and all of those things. So providing that intervention for sure will lengthen your ED length of stay.
Unless it's
It
done in
happened
the social
after
worker's office.
discharge
But I want to get back to the order because people were raising their hands. So I think we have Lou and then Maria and then the microphone.
I didn't like the idea about emphasizing triage. I think many years ago, we sort of stopped doing triage because I just assume have someone in a room with clothes off on a monitor and talk to the person and find out the story. And I don't mind. I like to send the student in if I've already checked to know that that's fine. So if someone spends 20 minutes with that person, I find out a lot, and then I can go and talk, and I can find out a lot in the person's language, in the person with a relaxed state. I don't want to know if a guy's got alcoholism or a woman's got alcoholism, that's a big problem. And I've got to find out why it's worse today to bring them here, or why it's worse every day. And I've got to spend the time. And the only way people will learn about the story of that person is to listen to that narrative. And it's not enough that the social worker gets it. The doctor has to learn that. the patient has to understand, it's pushing you to come to conclusions that you've never come before. Something's going to be found out that I can't abdicate to somebody else. So I think you can't, we used to have long histories. The nurse had a complete history. It was so big, the person would stay there long enough so almost everyone could walk out before the person got in. So then everyone came in and gets to the place, and the first person to see him or her is a doctor and a nurse together, and they'll work on it and they'll figure it out. And the only way you can do great research on homelessness is if you talk to a homeless person in the emergency department, or if you're going to do alcoholism work, to talk to the person and to listen and to get it yourself. So you have to know how to solve the problems. They are all soluble. They all really can be done, and there's a way to do it. And it does take more time for us, but it's much more effective. It's much better teaching. It's much better for the patient. The patient gets to talk about it. You get to see which brings the person to cry, which brings the person to talk about the child. What are the issues that have to be discussed? If you don't do that, no one else can do it. I mean, that's what being a doctor is fun to do, and that's what being a doctor is successful at doing, and finding out. You had a lot of advocates. I have the community board. I have everyone else, social worker, all sorts of people. I have volunteers, lots of people, but I've got to be embedded in the process. I think that's what doctoring is. And so it's about the patient, but listening to the patient, not someone else's collection of everything, but lots of people intervening in the process. And there's no shortcut to it. All the other things for the people we're worried about are not going to, we have to feel the pain, so we make some advantages for this patient by this experience. Otherwise, it's just a lost opportunity. Wait till the next time. Then when he's been hit by a car and then everybody rushes to take care of him, there's no sense getting a history any longer. It's too late.
Okay, just to recap here, we have Maria, and then Nate, Chris, Jocelyn, Maria, and then Stephen and Jay, and then down this line, and then we're going to be back to Ted.
Well, I wanted to just say two fairly brief things. One, Dr. Goldfrank is the person that taught me that, there's no poor historian, just poor history takers. But I can't count, at least multiple times during a shift, I have residents come up to me and they're like, this patient was a really poor historian. And I feel like that person when every time I'm like, okay, but there's no such thing as a poor historian, you just suck at taking it. Like, I don't want to say that to them. And so I kind of do it, I send them back and I say, well, why do you think they stopped taking the medications? Why did EMS bring this person in today? So I do think that's really important, and that is something that we can do a better job of impressing. And I'm grateful to Dr. Goldfrank to hear him say that over and over again, because it's true. But I also think the question about sort of getting people to clarify their reason that they're there, I guess I feel like that applies to everybody, not just people with poor social determinants of health. And so that's always a question. Like, why does anybody come to the emergency department? People have all kinds of reasons, and sometimes it's because they're having a heart attack, and sometimes it's because their dad had a heart attack at their same age, and they woke up in the middle of the night and had like a twinge and came in, and that person's not necessarily like disadvantaged or homeless or anything, but it's, I think we have to get at the bottom of that for everybody, and that's just part of, I guess, as people have been saying, being a good history taker, being a good doctor. And so I think that is, I guess, difficult and not restricted to a certain subset of patients.
Stephen?
So, Steve Anderson, Community, Blue Collar, Seattle, ACEP Board of Directors, EMF Board of Directors, pragmatist. But I, without tipping my hat, I gave a lecture yesterday at Colorado ACEP that I give all over the country called Dying to Ease the Pain, Reducing Recidivism Through Coordinating Care. There are 3 ways to change physician behavior. Number 1, economically incentivize it. Pay me, I'll learn how to do it that way. 2, peer embarrassment. Show me where I land on the bell curve, because most of us are good people and we want to do what's right. We'll change our behavior. That involves metrics and giving people feedback. The 3rd is make the right answer the easy answer. And then people will beat a pathway to your doorway. Technology can be part of the solution. Push me information, don't make it 3 clicks to crazy. If I have to go through 3 screens with a login, I'm not going to the PDMP unless I have to. But if you figure out triggers of who are the high-risk patients we're talking about, we're going to talk about the people that 5 visits to the emergency department in a year, because we know New York told us they die at a 48% times higher rate. Find the people that have attacked nurses in the past. Find the people that we know from the work that was done down the street 2 weeks ago, get them back on their Seroquel works. Treat their sickle cell this way. Turns out that if you coordinate their care, you identify these people up front and find solutions that have worked in the past. Could you imagine if you had that tool every time you clicked on your next patient? That tool exists. It exists in Washington State, Oregon, and it's going to go live in about 10 other states this year. I'll come back up here and talk later about the Emergency Department Information Exchange, but it identifies up front who's at risk. It tells you if there are solutions out there already that have worked, and it picks out our most at-risk patients. It doesn't label them, but it focuses. The TSA stopped years ago asking, are you carrying a bomb on board? It's not the triage question, it's the right question. And if you're upfront given the problem set that this social group has, you can go in and you can start drilling down on why wasn't it solved last time? Why are you back for the 23rd time? So we're looking for tools. There are some tools out there, and happy to share them. Thanks.
Okay.
Jay Shore from Brigham and Women's Hospital. A couple of comments. The first is about the triple aim. I think the triple aim really is the friend of this movement. And if you think back to when Don Berwick introduced the triple aim at IHI, and then when it got taken to CMS, what it really did is introduced population health and cost into the whole idea of the things we're going to measure in healthcare. Before that, all of the measurement was very process of care measured within institutions. And so I think there are currently lots of opportunities at CMS and other agencies to help shape measures that are going to make our institutions value this work. So measures around healthy days at home, measures around care coordination are being developed by Medicare, and there's a role for us to speak up about those. The second comment I would make is just in another way that we can be active in this, and maybe one of the most urgent ways is within our own institutions. I'm someone who started out mostly doing research, and now the majority of my time is on administration. And within my hospital, which is a not-for-profit hospital, but not a public safety net hospital, I go to multiple meetings per day where the unspoken narrative at the meeting is not social benefit. It is not addressing our community benefit. And if we are prioritizing bringing in the high-margin neurosurgical patient, what does that do to the patients who walk in or come in by ambulance who we give care to? And so speaking up in our institutions for our missions at those meetings, I think is extremely important. And it's hard to do, but we're the people who are best able to do it because as physicians, we both take care of the patients and have a seat at the table in our institutions.
Nate?
I would just encourage us to also look at these through the lens of health disparities. Because if you think about it, sit down and actually having an in-depth conversation with your patient allows you to have more of a empathetic and humanistic sort of bond with that person, and helps to break down a lot of the implicit biases that we all hold, right? And so, you know, I think this sort of movement is going to sort of encompass a lot of different sort of buzzwords, so to speak, in terms of initiatives that are, you know, CMS driven or health system driven, but sort of think about the impact that these things can do just beyond easy dispositions, but also sort of building better patient relationships, making better decisions, and helping us to sort of get rid of some of these biases that we hold and we're not sure of, right? If every person that I think of as a homeless alcoholic, I'm never going to get rid of that bias. When I see the 65-year-old female who's dressed to the nines and is, making $500,000 a year and she's the alcoholic, that changes your perspective, right? And so it's important for us to really look at these things not only as a way of doing better care for patients, but also sort of getting rid of some of the issues that we're creating in the health system as well.
Chris? So I want to give an example of something that we went through in my practice years back. And it's an example of how our interests as physicians align with patients in addressing the social determinants. It used to be like 10 years ago that dealing with the patient experiencing acute pain was the most difficult patient for me to work with. And there wasn't a shift that I could walk away from and I didn't have a fight over not prescribing opiates. And I live and work in Western New England, and we are an epicenter of opiate addiction. And in 2009, a lot of us will work at a number of hospitals, and we would see patients migrating from one hospital to the next with the same complaint, but we weren't sharing information. We identified, okay, this is happening, and we wrote our first opioid prescription guidelines for our department in 2009. And it would have been really nice if we knew other people were doing it, because they were. And it wasn't until, and once we started to do that, it got a little bit better, but it wasn't until the country decided, okay, opiates are a huge problem. And in 2014, my town actually, Bennington, Vermont, was on the front page of the New York Times as, the epicenter of the scourge of heroin. And finally, everybody's like, got it. It's like, okay, this is a problem, and they threw resources and money at it, they coordinated care, and now we have the monitoring databases, and it's so much easier. And in 2007, if a patient wasn't happy that I didn't prescribe Percocet, they would go down to the VP of patient satisfaction, and I'd have to answer to that VP and why I made this person happy. And so there are systems that we create organizationally that make our job harder. And if there's some way that we can address determinants in a more functional way and stay ahead of the emerging trend and communicate about that, then maybe we can save ourselves a whole lot of pain. And this to me is like the best argument for the prescription monitoring database. I mean, it doesn't need to be rolled out like they do it now in Vermont and Massachusetts, where you have to look at every single patient every time you prescribe something. But we could do it better and smarter. And maybe one of the things that we can develop from this body is at least the blueprint on how to create a network of reporting emerging trends and communicating on solutions.
Jocelyn, and then the microphone.
I think that's a good segue for me. I was going to comment twofold on who does the screening, because I agree with Dr. Irvin and Goldfrank about we need to incorporate this in the physician-patient conversation. But I think most of you also know if you're working alone, and if I'm working at 2 a.m. at Highland, I have 48 patients and 2, maybe 3 residents, and I can't ensure that every patient is getting the social determinant screen. But we do have health coaches in our emergency department, and Dr. Irvin and Dr. Corbin have validated screens for trauma, and we have screens for stress and depression that a young person who looks like that patient can spend 15 minutes with them and talk about it. It's just an option, not to take away this is something we should do and include in the education, but you also have options to get a young person and hire them and expose them to social determinants and have them do it to offload the physician from having to do everything.
Dr. Corbin.
I want to thank everyone for this rich conversation and also being invited. Ted Corbin from Drexel University in Philadelphia. A couple of things come to mind. A couple of things that might be somewhat simplistic, but something that I actually learned from Thea James is just we do something for our residents, and it's not for the community hospitals, but there's some answers to some solutions. And I feel that where there might be a residency, be it in a rural area or an urban area, it's important for the residents to know where their patients come from. And some of us coming from places of privilege that don't understand what social determinants are, that's a really, really ripe environment for our residents to get an understanding. I mean, when I was in medical school, it was that we had patients that came in and talked to us about their experience, and we got to understand that. It's another space when we have, unfortunately, it happens during M&M conference, but we bring back some of our victims of violence that have gone through some of the programs that we have in place, working with the social workers or the community health workers to tell their story. And you can see light bulbs go up for some of the residents that are in our program that haven't really had a sense or understanding what some of our patients encounter or experience. The last thing is I want to come back to the issue of social medicine as we move forward, because I value it and I think it's extremely important, but just keeping in mind some of the unintended consequences that go along with that is that there are some efforts that are in place already, and we don't want to reinvent some of those, but rather partner with them. I think in ACEP, there is the LGBTQ community, which falls under social emergency medicine. There's disparities in minority health and minorities in medicine, women in medicine, all of that kind of somehow falls under the purview of social emergency medicine. So I think it's important for us to hone some of those bullet points that we know will fall under our wheelhouse, but also partner where we have opportunities to do so, where things are already happening and have some traction.
Austin?
Austin Kilroot from Highland. So to the original question, one of the early questions in the discussion about what our role is as emergency physicians, I think it's not just about who we are in terms of being physicians and having other demands in terms of our volume and the number of patients we see. It's also, again, what Jocelyn was saying about when we practice and where we're practicing. It's very hard to make social EM interventions at 3 o'clock in the morning. It's not hard to screen. I think you can screen 24 hours a day, but to make interventions, we need good peri-shift resources that we can access that can happen during the day. Even the best of our social workers can't find housing for someone at 3 a.m. And I think something that we haven't really mentioned yet is in addition to health coaches and social workers, case management, is that there is a growing trend in the way that our healthcare is delivered around patient-centered medical homes. And I think we have to discuss how we integrate our efforts as emergency physicians with ambulatory care and this new medical home model. And so I think we should probably just make sure that our partners are not just in the public health world, but also other physicians that are primary care providers.
I think Jay and then Maria and Kelly. I got everybody?
Jahan.
Oh, and Jahan. Oh. Okay. Got
it. Okay, quick comment. And this has to do with what we're teaching our residents and even how we work as emergency physicians in terms of caring for our patients, and it incorporates some of what's already been talked about. To me, a lot of what we teach residents these days is about task. We are very task-oriented in healthcare today. When I think we understand that what's most important to our patients, and I'll just harken back to a phrase that I used to think was very trite, which is people don't care how much you know until they know how much you care. That when I ask a resident, what's your job when you go in to see a patient, they say it's to find out what's going on with the patient and make the diagnosis. And I say, well, that's really about task. Your first job when you walk into the room is establish a relationship with the patient. And to me, every patient interaction has a beginning, a middle, and an end. The beginning is about establishing a relationship with the patient. The middle is about the task of doing your history, doing your physical, finding out, determining a diagnostic workup and plan and communicating that to the patient. And then the end really is about relationship again. When you walk out, it's about making sure that the patient understands what's going on. And in fact, when they leave, to make sure that they have their questions answered and that you've taken into account their social situation. That's not what we're teaching a lot of our residents these days. And that in fact, we don't really teach a communication methodology to our patients. And so what I've worked with physicians, not just in the emergency department, but hospitalists and physicians in the office practice setting. And what we've been teaching now is that every patient interaction is about RTR, it's about relationship, task, relationship. And if we start to teach our residents that, then the issues that we're talking about in terms of the social determinants of care get talked about much more commonly than if it's just about the diagnosis and treatment of the patient's illness.
So Maria, Kelly, Jahan, Jerry.
To say related to what someone was just saying about the need to connect resources outside the emergency department, which I won't talk about it too much, otherwise I won't have anything to say when I actually have to present my paper. But I did want to mention that at the emergency department at UCSF, we have implemented EDDI, as Stephen mentioned, the Emergency Department Information Exchange, and we do have 2 healthcare navigators that are, they're college, they happen to be college grads, but they don't have licenses or anything like that per se, and they are there to sort of supplement the work of the doctors and doing the kind of screening that we're talking about and kind of helping to get to the bottom maybe a little bit more about what are some of the factors that are bringing someone into the emergency department often. And I feel like their role is to really kind of supplement what the doctors are doing and kind of like inform some of the doctors and residents and mid-levels and nurses about like, oh, by the way, we just found this out about this patient, or we through the portal, we were able to gather this additional information about the patient that like would be helpful for you to know. So you don't have to order another scan because they just got 3 scans and they were normal, or whatever the case may be. And the other thing we have them do is, email the patient's primary care provider, let them know why they were there, and see if they have anything to contribute to the care plan that we'll put in EDDI. So and we'll do that for an outside case manager, a housing case manager, someone from the general. Often Hemel and I are working together because a lot of the patients are going between institutions, and they do have providers out in the community or at the different institutions whose voices need to be heard by the ED provider when the patient's in the ED. So it's sort of about coordinating, gathering information, coordinating, and putting it into some notes that are appropriate for the ED physician, but then also doing a little work beyond that and meeting the patient in the community, actually. So they'll leave the ED, go out and follow up with the patient in the community. They'll start applications for patients in terms of housing applications, Obama phones, establish, we let them use our mailboxes at UCSF as their address, so they don't have an address, so that because a lot of the processes are 2-step processes. So, I don't think that it'd be realistic to ask a physician to do any of that. Like, that's just not our kind of wheelhouse, but I think that they can be really effective at doing those kinds of things.
Kelly, Jahan, Jerry, and then I think we have to break. Jerry gets the last word.
Kelly Doran from NYU. I think I'm just channeling a little bit of what Dr. James and Dr. Khaldun said, but I still keep hearing some angst around the room around kind of, well, if we ask about these questions, how are we going to address them, or what will the interventions be? And I just think we should recognize that there's a kind of a continuum, right? So if we find out that a patient is homeless, an intervention would be getting them housing, and that would be fantastic. But even barring that, or even barring some of the types of great interventions that Dr. Raymond was talking about, that information, even within our normal scope of practice of emergency physicians, is something that we can act upon. For example, if this is a patient that has pneumonia and is homeless, and we know that there's no way in heck that that person's going to be able to get their antibiotics and do well on the streets, then we can come up with an alternate care plan, whether it be referring that person to a respite center if one exists in your community, or admitting them to the hospital. So, there's a continuum, and so I don't think it's pointless to ask these questions, because I do think that there are ways that we can address it already that are in our normal playbook as emergency physicians.
Jahan?
Jahan Fahimi from UCSF. One thing that kind of taking a step back has been alluded to a little bit is I worry a little bit that sometimes the social determinants are actually used against patients. I mean, we're talking about let's screen for them so that we can address them, so we can do better. And a lot of times, unfortunately, you hear from physicians or nurses or staff about social determinants that are used in a derogatory way to describe someone who's frequently in the ED. And we have to, and perhaps if we have a solution for the social determinants, that maybe that will change people's minds about how they view them. But we also kind of change that culture in where we practice, so that people don't say, this is the 4th time he's here, he's always drunk. And so that we don't say, this guy, he's homeless, he's a quick one, I'll get him out of here real fast. And you hear that frequently, and I think that that's, it's a trap that a lot of our providers, nurses, residents, physicians fall into.
Jerry?
Yeah, 2 comments. One is I would like to suggest that we reconsider the use of the word screening for what we're talking about. Screening is what you do when it has no relation to what the patient's there for. It's a sort of a general complaint, and I'm going to also, while you're here, I'm going to look for other things. I have no reason to believe this is an issue with you, but I'm going to ask because it might come up with something. Without getting into the many reasons why screening, well-intentioned screening, usually fails, I think the reason we ask these questions is because they are a part and parcel of why the patient's there, and because if you don't ask them, you won't figure out why the patient's there. So it's the wrong mindset to think about this as screening. This is part of the history about the acute illness. And that reminds me that the reason we do it is not because we're nice people, but because it's the only way to help the patient. And so when I suggested, I think you're referring to my comment before when you talk about, well, feeling frustrated that there's nothing you can do about it. By no means do I mean to suggest that there's nothing we can do with the information. What I do believe, though, is that many practicing docs think there's nothing they would do with that information. It's just screening. You're just getting me to do another question that I resent asking, and then I don't know what to do with it. That would make things worse rather than better. So I think one of the critical things is to educate all of us in our profession that these questions are relevant to this patient, why they're there now, that if you don't ask them, you can't provide good care, and that if you do ask them, there are a series of things that you can do, but we need to spread that word. We can't just say it amongst ourselves that it's a good thing. We're not asking because we're nice. We're asking because that's the only way we can be a good emergency physician.
I think many of us have been talking about social emergency medicine as the incorporation of social context into clinical and population care, and I think that's exactly what you're talking about. Before we break for lunch, the executive director of the American College would like to say a few words, I think.
Thank you. Yes, I asked the staff if I could just come in and say a word of welcome. Thank you all for coming to our, that's it. Got my Dr. Kathy.
To run.
Yeah, I want to thank you all for coming in to our new headquarters. I understand you may have an opportunity to take a look around in a little while and take a tour. I really want to commend you for what you're doing here and kind of thinking outside the box. ACEP has a rich history of involvement and positions in public health and injury prevention. The opioid crisis currently, human trafficking, gun injury prevention, traffic safety. And I know those are, as I understand it, there's some overlap of circles from some of the broader societal things that you were looking at. I also would say that our mission is kind of divided into two large buckets. One is to advance the highest quality of emergency care. And second is to be the leading advocate for emergency physicians, our patients, and the public. And you can certainly make a strong case that we can't do either one of those effectively unless we understand other societal things that impact the patients and our mission. I was also just told a moment ago that we have now successfully formed a social emergency medicine section of ACEP. We have to have 100 members to form a section, which is like a special interest group. And each section has a counselor on the council floor that can debate things and introduce resolutions and so forth. So I want to encourage everyone who's here who may not have joined that yet to please consider joining that. And again, I just want to thank you all and look forward to what comes out of the meeting. So thank you.
Thank you for your hospitality.